Welcome to our presentation on antisocial personality disorder, presented by Amanda Browning and Ralph Stahl. According to the DSM-5, antisocial personality disorder, or ASPD, is characterized by a lack of respect for other people's rights occurring since age 15, indicated by at least three of the following: an inability to follow social norms and laws, a pattern of deceitfulness, impulsivity or the inability to pre-plan, continual irritability and aggression indicated by physical altercations or assaults, thoughtless disregard for the safety of oneself or another, a pattern of irresponsibility and/or a lack of remorse. In order to fit this diagnosis, the individual must also be at least 18 years old, have evidence of conduct disorder with an onset prior to age 15, and the behavioral disturbance does not occur during a schizophrenic or bipolar episode. According to the DSM-5, prevalence rates fluctuate between 0.2% and 3.3%. Individuals with a lower socioeconomic status are also at a higher risk. Research suggests that there may be a biological component that increases the risk of ASPD diagnosis in biological family members. Chances of being diagnosed with antisocial personality disorder are higher in biological relatives of females diagnosed with ASPD. Interestingly, adopted children of individuals with ASPD are also at a higher risk. Due to the symptomology and behavioral issues present in this diagnosis, other disorders such as substance use or abuse problems, other personality disorders, anxiety and depressive disorders, and other impulse control disorders commonly co-occur in individuals with ASPD. Research shows that early identification of conduct problems can lead to more positive outcomes. Conduct problems in children are predictive of antisocial personality disorder in later life. A study by Hill states that there are many factors that determine both conduct problems and antisocial problems, including parental discipline, peer relationships, educational problems, and unstable family life. The differentiation of psychopathy versus ASPD can be rather difficult. These labels are often used interchangeably, but it is important to realize that there are specific differences. The criteria for psychopathy includes personality and behavioral aspects, such as grandiosity, the inability to feel love, and poor decision-making, whereas ASPD does not. There tends to be a great deal of overdiagnosis of psychopathy and ASPD in the criminal population. The Psychopathology Checklist Revised, or PCLR, assesses for psychopathy, and the overlap with ASPD diagnosis requirements is about 37.5% in the interpersonal symptoms and about 60% in the social deviant symptoms, which suggests that ASPD is more behaviorally based, while psychopathy is more personality based. Treatment planning is a vital step in the improvement of symptoms in individuals with ASPD. After assessing for severity and any other treatable disorders, there are 4 areas of concern that need to be addressed in regards to treatment planning. Risk assessment includes safety of the individual, staff, other members, and the security of the facility. Personality characteristics of the individual, which may include anxiety, narcissism, psychological defenses, and patient affect. The ways in which the clinician reacts to patients needs to be addressed as well. Common reactions include fear of harm, loss of professional identity, helplessness and guilt, denial and deception. And finally, what specific treatments would be most effective for each patient needs to be discussed. Treatment as usual, or TAU, has been shown to be effective in the treatment of ASPD. TAU is often used for substance use reduction, which is a very common co-occurring disorder with ASPD. Combining a modified therapeutic community and TAU, one study showed a reduction in substance use and the rate of recidivism 1 year after release. TAU plus cognitive behavioral therapy has also shown to reduce aggressive behavior. In a recent study, effects of the use of TAU alone and TAU combined with CBT were examined. Results showed that both TAU alone and TAU plus CBT showed promising results for physical and verbal aggression. Another study showed that risperidone has been effective for treating aggression and impulsivity. However, this study only included information from one individual, so more research is warranted to ascertain whether or not risperidone truly is effective.
I'm now going to talk about several other treatment options available, all of which have their basis in cognitive behavioral therapy or in that family of thinking. First one is enhanced thinking skills. Basically, teaching you to think more about why you do what you do. It had an effect of reducing reoffending rates in prisoners by 6%. Impulsive lifestyle counseling is another relatively short-term treatment option that basically had some moderate impacts on reducing aggression and substance abuse. And as the name might imply, reducing impulsive reactions. A third option is empathy training. People with antisocial personality disorder typically have had traumatic and dysfunctional childhoods. So often they've shut off feelings, and if you can't feel for yourself, it's also difficulty to feel for somebody else and have empathy. There's also an issue of shame versus guilt. Typically people with ASPD have a lot of shame, and they think that they are bad, not what they have done is bad. One of the more effective therapy options is dialectical behavioral therapy. Basically, it involves bringing resolution or synthesis to conflicting emotions. It's a fairly long-term approach, but one of the more effective ones. Another option is cognitive therapy, which focuses on changing thinking errors. And it basically involves self-discovery and also reinterpreting past experiences, particularly childhood experiences that are impacting present-day behaviors. Mentalization-based therapy is rooted in the notion that antisocial personality disorder is rooted in insecure attachment and early childhood developmental issues. So basically, mentalization-based therapy attempts to help people understand their emotions, their thoughts, and their feelings, their motivations for doing things better, and essentially is almost a replacement for the lack of secure attachment that took place in childhood. The goal is to help clients to begin to feel again, because for many of them, becoming numb was a coping mechanism. Another option that has taken hold in Europe is the model of democratic therapeutic communities, which is essentially used in prisons, that rather than having everything decided for the prisoners, that they have the option of making decisions, working collaboratively with their fellow inmates and with their treatment specialists, basically to help encourage and model prosocial behavior within the prison setting. created mankind to be in relationship both with Him and with others. But our sin nature is what draws us towards selfish behaviors and antisocial behaviors. The antidote to antisocial personality disorder is authentic relationship, both with a therapist and with other community members or family members. But ultimately, lasting transformation and healing from antisocial personality disorder would come from a saving relationship with Jesus Christ. We can often change our behaviors on the surface, but the lasting change comes through a heart change. Antisocial personality disorder is notoriously difficult to treat and often has been considered untreatable. Cognitive-based therapies are the most effective, and ultimately, therapy involves learning what it truly means to be human, to feel, to love, to care, to be in relationship with others. God can transform anyone, no matter what they've done in their past or how antisocial they are. But He may just want to use you or me to accomplish that goal. Thank you for listening to our presentation on antisocial personality disorder.